Hi, everybody. We're going to talk about the oral cavity and the esophagus. So, oral and esophageal problems can compromise tissue integrity, impair nutritional status. People can't chew, they can't swallow, they're not going to get their nutrition. Could impair their gas exchange because the pharynx is part of this system as well. So if there's swelling or if there's some kind of disease process going on, it could impair their gas exchange and also cause a lot of pain. So we've talked about teeth before. You know how many teeth there are. We've talked about saliva. But there are oral cavity disorders that can be very severe and affect whether the person can eat and cause a lot of pain. So stomatitis is one of those problems. It's a broad term that refers to inflammation within the oral cavity. So it's painful, inflamed ulcerations called aphthous ulcers or canker sores erode the tissue integrity. And you might have seen, or maybe even yourself, you have had a cold sore. I mean, those are pretty painful. So possibly you know what that feels like. And then there are other conditions. If you've ever had thrush or known anyone to have thrush, can also cause a considerable amount of pain. So again, this is just taking a look at the anatomy. So you know that digestion of food begins within the mouth when we start to chew something, and saliva gets in there and helps us start breaking down carbohydrates. The pharynx or the throat is between the mouth and the GI tract, and it has a role in both digestion and gas exchange. So air is breathed in through the nose and passes down the nasopharynx into the oral pharynx and down into the trachea. Therefore, when there's an issue with this area, we see problems arise with gas exchange and digestion. So again, stomatitis. Primary stomatitis is the most common type, and it includes aphthous stomatitis or non-infectious stomatitis, herpes simplex, stomatitis, and traumatic ulcers. So that's primary. Secondary stomatitis generally results from infection by an opportunistic virus, a fungus, or bacteria in patients who are already immunocompromised or as a result of chemotherapy, radiation, or some kind of steroid therapy. There's a common type of stomatitis called Candida albicans, which is sometimes present in small amounts in the mouth, especially in older adults. But just remember, this is one of those reasons why I say we do a head-to-toe assessment, and you should never skip over looking in someone's mouth, especially in someone who is hospitalized, who is on a lot of antibiotics. Because just remember about antibiotics, they don't just kill the bacteria that we are trying to treat, they kill our good bacteria as well, our good bacteria, including those good bacteria in our GI tract. And I'll talk a lot about this later as well when we get into the lower GI system. But so if we're killing all the good bacteria that make residence in our mouth, we don't have a way to fight infections in our mouth, so we get what are an opportunistic yeast infection called Candida albicans or thrush. So long-term antibiotic therapy can destroy that normal flora, which allows the Candida to overgrow, and then that results in candidiasis or moniliasis, a painful fungal infection known as thrush. People have so much pain with this sometimes that they cannot even drink water. So you're certainly not going to give them something like orange juice or something else acidic, cranberry juice, something like that, to drink. So please be careful with that. So stomatitis can result from an infection. It can result from an allergy, any kind of mineral deficiency or vitamin deficiency, especially B vitamins, zinc, iron, folic acid. It can result from a systemic disease and irritants. And those irritants can be tobacco and alcohol. Those irritants, like tobacco and alcohol, can also contribute to oral cancer. Just keep that in mind. Certain foods like coffee, potatoes, cheese, nuts, citrus fruits, and gluten may trigger allergic response that cause aphthous ulcers. Aphthous ulcers. So again, this is just telling you what stomatitis is. And we may have to actually, again, I said it's very painful, and we might even have to treat it with opioids because of the extent and the pain. And of course, if the person has Candida albicans, the yeast infection, they're going to get an antifungal. So ulcerations appear as inflammation and erosion of the protective lining of the mouth of the patient. Sores can cause discomfort and put a patient at risk for bleeding and infection. Interventions for stomatitis then are targeted toward health promotion and reduced risk for infection through careful oral hygiene and food selection. So you know that you're not going to tell somebody with stomatitis who already has a considerable amount of pain to use Listerine or Scope. Like I said, they can sometimes not even stand to drink water. So be very careful. And as far as oral hygiene, you know, if they're able to even use a toothbrush, you would want to make sure it's a very soft toothbrush and avoid any kind of alcohol-containing mouthwash or anything acidic. So proper oral hygiene can decrease the frequency and severity of stomatitis, but that doesn't mean that people who are getting chemo or radiation, you know, even if they do the proper oral hygiene, they still can get those problems because they are immunocompromised and at risk for those opportunistic infections like yeast infections or thrush. So I already mentioned these types of stomatitis. So again, they're classified on the base of the cause. So the aphthous is non-infectious. So again, it might be a traumatic ulcer from like a tooth rubbing against the inside of your mouth, or braces, something like that. And then secondary results from an opportunistic infection. So just remember that Candida or yeast is a common opportunistic infection. The normal flora is destroyed, possibly by antibiotics, possibly by radiation, or even steroids, and allows the Candida to overgrow. Stomatitis can also occur from allergies and vitamin deficiencies, as I previously mentioned. And don't forget the alcohol and tobacco, which can also put them at a higher risk for oral cancer. So when you're assessing someone with stomatitis, what is their history? Like what you know, have they had radiation? Have they had chemotherapy? Have they been taking a lot of antibiotics? That type of thing. If they have lesions in their mouth, does it interfere with eating or swallowing or even talking? So severe stomatitis and edema have the potential to obstruct the airway again, don't forget, like sometimes this stuff gets thick. Like look at the picture there on the bottom of that thrush. They're big, like plaquey like things, and those can come off of the tongue and actually obstruct the airway. Or the airway could get so edematous that it would block off the passageway, and the person would be not able to breathe as well. So just make sure when you're doing a head-to-toe assessment on every patient in the hospital that you are wearing gloves after you do your hand hygiene, and that you are using a pen light and a tongue blade, and you are looking in their mouth to make sure that you don't see any of this plaque that they have. So any good oral hygiene helps to discourage stomatitis. However, it's not always completely preventable, as in the case of people who are immunocompromised. So interventions for stomatitis. There is a little box on page 1076, maintaining a healthy oral cavity. Just kind of look over that. There's also an action alert on that same page. It is talking about airway obstruction, aspiration, pneumonia, and malnutrition resulting from having difficulty swallowing. So again, look at that, maintaining a healthy oral cavity, and then there's best practice for patient safety and quality care. So again, I mentioned this already, but you make sure the person is using a soft toothbrush. And again, stomatitis is most often very painful. So what can the patient eat? This is important. Dietary changes may help decrease the discomfort. Cool liquids can be soothing. Hard, spicy, or salty or acidic foods or fluids can further irritate the ulcers. Include high protein and vitamin C foods. Remember about, in the nutrition section, we talked about healing and tissue repair. Well, that's part of this, because under those nasty white plaques is very raw tongue and throat. So you want to make sure that we are building that back up. So when we talk about high protein foods, that's one thing. We can give people custards and puddings and things like that that are soft, but we do not want to include any kind of acidic juices or fruits to give them the vitamin C that they need for their tissue healing. So scrambled eggs, custard, pudding, bananas, ice cream. That is on page 1077, where it says under interventions, cool or cold liquids can be very soothing, whereas hard, spicy, salty, and acidic foods or fluids can further irritate the ulcers. So again, just read that there. Could also try some over-the-counter anesthetics like Orabase or Anbesol. I'm sure you've heard of Oragel for babies, or even viscous lidocaine. But people need to be very cautious when using viscous lidocaine. That is a topical anesthetic agent. Lidocaine causes a topical anesthetic effect, so patients cannot easily feel if the food is too hot, so they may burn themselves. So just make sure that you're pointing that out to people. Another problem, and this is on page 1077, erythroplakia, is a red velvety mucosal lesion on the surface of oral mucosa. It is precancerous. And they should be able to biopsy that, but it's very difficult to distinguish from some kind of an immune response or some kind of an inflammatory response. So most of the time it's on the tongue or the palate. And again, difficult to distinguish from an inflammatory or an immune reaction. So here's another example of erythroplakia. And just remember that is precancerous. On the other hand, there is leukoplakia, which is often confused with candidiasis. But if you look at this and you look at a picture of candidiasis like the one on page 1076, you can tell this particular, at least on this particular picture, leukoplakia, you cannot flake that off. It's thick, white, firmly attached patches that cannot be scraped off, unlike the candidiasis, which can be scraped off. So just make sure that you realize that. Oral hairy leukoplakia is found in patients with HIV and indicates progression to AIDS. It's also associated with the Epstein-Barr virus. So again, this is just showing you the difference between leukoplakia and oral candidiasis. So one you can flake off and the other one you cannot. And just remember that candidiasis, another frequently used term is thrush. Okay, that leads to oral cancer. So prevention strategies include stopping the use of alcohol and tobacco, avoiding sun exposure to the lips, avoiding exposure to HPV and sexually transmitted infections. People who tend to get oral cancers are plumbers, textile workers, coal and metal workers who have prolonged exposure to certain types of plastic or aromatic hydrocarbons, especially if they have also got or had an exposure to human papillomavirus. People with periodontal disease, in which mandibular or jawbone loss has occurred, are also at risk for oral cancer. So make sure that you know those risks. The picture there shows a squamous cell carcinoma of someone's tongue. So these cancers start on the surface of the epithelium and they have dysplastic changes to the epithelium, and then they get a tumor that looks like this after the cells are overgrowing and kind of run amok. So lesions may be large before symptoms unless there are ulcerations. Mucosal erythroplasia, so that's redness again, is the earliest sign of oral cancer. So it's an oral lesion that appears as a red, raised, and eroded area that looks suspicious. And again, can't tell you enough, the most prone are people who smoke and drink alcohol. So risk factors: increasing age, tobacco and alcohol use, work with exposure to polycyclic aromatic hydrocarbons, periodontal disease, and sun exposure, poor nutrition, and poor oral hygiene, and the HPV virus. So over many years, those pre-malignant cells begin to form and vary in size and shape. So alterations in the thickness of the lining of the epithelium to develop, resulting in atrophy. It's usually slow growing. The lesions may be large again before symptoms appear. So these polycyclic aromatic hydrocarbons are a group of over 100 different chemicals that are formed during the incomplete burning of coal, oil, and gas, garbage, or other organic substances like tobacco or charbroiled meat. Basal cell carcinoma, and there again is a picture of a basal cell carcinoma, and this one occurs primarily on the lips. It's the second most common type of oral cancer. Lesions are asymptomatic and they resemble little scabs, and over time they get to look like ulcers. They don't metastasize, but are aggressively attack the skin on the face. So again, how does one get basal cell carcinoma? Generally from a tanning bed or excess sunlight exposure. So this is why, everybody, dermatologists in particular, are always saying to wear your sunscreen. Kaposi sarcoma. This is a common cancer that is in the HIV/AIDS population. Most common on the hard palate in the mouth when found in the oral cavity. It can be found in the gums, the tongue, and the tonsils. But Kaposi sarcoma can occur anywhere on the skin. Most of the time they are painless, so a person doesn't really know that they have them. And something I want to reiterate on all of these lesions: mouth lesions, stomatitis, thrush, all of these things. Oral cavity lesions can be treated by surgical excision, but just remember that airway maintenance is a priority of care for patients with any kind of oral cancer. So that airway, make sure we're maintaining the airway. On page 1079, there is a box of key features of oral cancer. And that's just pretty much for your information. And there those are. So you can take a look at those. So once again, I want to say, just like the action alert under the nursing safety priority on page 1079, it says aspirations, precautions must be instituted for patients with oral cancer. So saying again, when you do an assessment on any patient in the hospital, you need to inspect their mouth for lesions. Many, many, many of your patients are going to be on a lot of antibiotics, even over a long term when they're in the hospital. Is this person having any discomfort? Can they swallow? Is it painful to eat? Can they talk? Is there a change in their voice that they notice or their family noticed? Is there even saliva? Do they have saliva present? Biopsies may be necessary for many of the lesions found. So intervention, we can surgically excise lesions from the mouth. And again, we're talking about oral cancer, so the most things that we do for any type of cancer is surgical excision, chemotherapy, radiation, or a combination of those. One type of radiation therapy used is called brachytherapy. Brachytherapy is there are different types of brachytherapy. Sometimes they implant rods or little seeds around or within the tumor, and we get the radiation to the patient that way. So they're actually like little seeds or little rods or something that are implanted into the person. So brachytherapy, if it's used for oral cancer, it's going to be really close to the face and neck. So again, I'm telling you that radiation is just right there. So what is it going to affect? It's going to affect the person's taste, and it could cause really thick saliva, or even no saliva. So people may get an actual type of artificial saliva that they need to maintain their oral mucosa, because we don't want their oral mucosa to be dried out. So other non-surgical management: promote deep breathing, suction, available, because again, maintaining airway, positioning to a semi-Fowler to Fowler's position, so elevate the head of their bed basically. Fluids, chest physiotherapy, they may require steroids, they may require antibiotics. Cool mist, oral hygiene every 2 hours, very soft bristle toothbrush. It says watch platelet count. So chemo and radiation do a lot to the person's complete blood count. So platelet counts that are low will show us that the patient is predisposed and has a risk for bleeding. So we want to watch for that. Discourage the use of toothettes, and those are, they may contain lemon glycerin, and they also make lemon glycerin swabs, but we don't want to use those because, again, those are acidic and they can dry out the mucosa. And not only that, but they are painful if someone has stomatitis as well. Keep the lips moist and avoid alcohol-containing mouthwash. So areas of concern with oral cancer: we want to monitor the airway, the oral mucosa, digestion. The person can have thick, stringy secretions. Make sure you're protecting and maintaining that airway. And yeah, just monitor for a patient's sense of taste also. So radiation, external or interstitial, and the interstitial is what I was talking about. And there is a term for that. It's called brachytherapy. And I believe it is chapter 20. Let me look in my book. I think it's chapter 20 where they talk about cancer. I could be wrong. Nope, concepts of care for patients with cancer is in chapter 20. And they do talk about radiation in this chapter. On page 380 and 381, you might want to look at that. It explains what brachytherapy is. So brachytherapy is internal radiation therapy. So they can use seeds or ribbons or capsules and put it directly in continuous contact with the tumor for a specified period of time. So if you look on page 380 and 381, it tells you a little bit about what brachytherapy is. Also, this slide says the person is generally hospitalized. With radiation precautions, visitors may only stay for 30 minutes or less. And since this is on the face and could obstruct airway, and I'm just talking strictly about oral cancer, a tracheostomy may be required. They can do brachytherapy with radiation, brachytherapy with external radiation, I should say, and chemotherapy. So it's just and even a surgical procedure. So just keep that in mind that we can use all three for cancer if needed. So surgical management, they can use laser therapy to remove the tumor, cryotherapy, which is extreme cold, to remove the cancer. But the surgical management depends on the size and location of the tumor, whether it's metastasized somewhere else, and whether it's metastasized to the bone or the lymph nodes. So I took care of a gentleman right out of nursing school when I worked in the ICU. He was alcoholic and he smoked a lot, and he had a lesion on his tongue, and he basically had half of his mandible removed and part of his tongue removed, so a hemiglossectomy and a mandibulectomy. So he, needless to say, had a tracheostomy. He did survive, but I did not see him after he left the ICU. So again, people that drink alcohol and smoke, they may not think it's that harmful, but it can be in the long term. Small non-invasive lesions can be removed under local anesthesia and then sutured, but bigger lesions would need maybe something like I described to you. So on page 1081, no, I think that's, no, sorry, 1080. They talk about some different surgical procedures like neck dissection. The man that I took care of had, let's see, he had a glossectomy, laryngectomy, mandible resection, maxillectomy, and a neck dissection. So he had a lot of those surgical procedures in his one surgery that he had. So it can be very extensive. Even if you think it's a small oral cancer tumor, it can require extensive resection and extensive surgery. So complications from radiation to the head or neck can be acute or delayed. Like they can show up much later. Acute treatment related are mucositis, stomatitis, and alterations in taste. Long term, it says xerostomia, and xerostomia is dry mouth, and again, they may have to have some kind of artificial saliva, and they can get a lot of cavities from radiation. Fatigue is common with both chemo and radiation. So depending on what the person had, as far as self-management, we're not going to go through all of this, but they do have a little section on page 1080 of care of the patient with oral cancer at home. So you might want to just look at that. So again, it's going to depend on how extensive. Maybe the person has a trach, dressings, that type of thing. So this slide says as well, loss of taste may be permanent and xerostomia may be permanent. And they may have to use saliva substitutes. If they have external radiation, they may have skin breakdown. It's just like being burnt, like a really, really bad sunburn. If they have taste changes, like they may lose their taste completely, but they may also get taste changes in that they don't like the taste of meat, like beef or pork, because it leaves a metallic taste in their mouth. So they may need to add more seasoning to their food or use gravies or sauces to make the food more palatable. These people need high protein foods, maybe in the place of those meats, if they don't like the taste of meats, because again, they need to build their tissue back. They may need speech therapy involved to do swallowing exercises if there is dysphagia. They may need thickened liquids so that they do not aspirate and they can control their swallowing better. They may need dietary supplements like Ensure that are high in protein. Soft foods to prevent injury to the mucous membranes if they have stomatitis or bleeding. If they have external radiation, we don't use lotions or powders on them. We clean their face and neck with gentle, non-deodorant soaps. Use an electric razor to shave, and we don't use alcohol-based aftershave lotions. And I also want to say, if you have never taken care of somebody who is having external radiation treatments, they aim the beam of radiation at a certain place and they put indelible marker. They mark the skin with indelible marker. So if you ever see marker on somebody's skin, do not wash it off when you are bathing them. So disorders of the salivary glands is next up in your chapter. So acute sialadenitis, so it's Aladdin, sialadenitis is inflammation of the salivary gland caused by infectious agents and again radiation or some kind of immunologic disorder. Most commonly affects the parotid or submandibular glands in adults. So again, post-irradiation sialadenitis, the salivary glands are very sensitive to that radiation. So again, there's going to be a decreased amount of saliva. So they're going to get xerostomia, which can be temporary or permanent. On page 1081, it says, again, assess facial function as the branches of cranial nerve 7, don't forget your cranial nerves, it's the facial nerve, are near the salivary glands. The salivary glands are sensitive to ionizing radiation such as from radiation therapy or radioactive iodide treatment of thyroid cancer. Radiation of the salivary glands can cause pain and edema, which generally subside after several days. Exposure of the glands to radiation produces a type of sialadenitis known as xerostomia, which is very dry mouth caused by a severe reduction in the flow of saliva. So again, that xerostomia may be temporary or may be permanent. So again, taste can be affected by brachytherapy, external radiation, etc. I want you to look at table 49.1, factors contributing to decreased lower esophageal sphincters now, or sphincter pressure. So if you have questions about the mouth, please let me know. But we're going to move on to the esophagus. So esophageal problems. And this begins on page 1081. So gastroesophageal reflux disease is the nutritional concept exemplar that is in your book. So you'll be hearing a lot about GERD, which is the acronym for gastroesophageal reflux disease, GERD. And I'm also going to post a PowerPoint, which I wanted to go through with you in class that is a case study. So I'm going to post that and you can go through that yourself. It has the questions and it also has the answers on it. So you can go through that and that will help you as well. first thing I'll mention before we go into GERD is achalasia, which is another term. Achalasia is a swallowing problem, and it is a lower esophageal sphincter spasm. That is the cause of it. So achalasia makes it harder for the esophagus to move food into the stomach. If you look at that table 49.1, there are many factors that contribute to a decreased lower esophageal sphincter pressure. So when the esophageal sphincter does not stay closed and doesn't have enough pressure, that is why people get GERD. Stuff comes back up, our stomach contents come back up into the esophagus and basically cause some bad issues in our esophageal tissue. So there it shows on this picture the lower esophageal sphincter. There's the stomach, and again, if that sphincter is faulty, it will allow food and fluid back up into the esophagus. So GERD is a common chronic disease of reflux. So it's basically regurgitation of food and fluid back up into the esophagus. It's the most common GI disorder, upper GI disorder in the United States. It occurs most often in middle-aged and older adults. So it's the result of backward flow of stomach contents into the esophagus. Symptoms are related to exposing the esophageal mucosa to the irritating effects of gastric or duodenal contents, so inflammation occurs. So if you look at the picture again, the upper there's an upper esophageal sphincter they show that on the right side. It's at the proximal end of the esophagus or the upper esophagus. The lower esophageal sphincter is at the gastroesophageal junction, so between the stomach and the esophagus. With GERD, there's excessive relaxation of the lower esophageal sphincter, allowing the reflux or regurgitation of gastric contents into that esophagus, and that it continually is exposing the esophageal mucosa to those acids of the gastric contents. People who are overweight or pregnant have an increase in intra-abdominal pressure that contributes to that reflux. Lying flat, like when we go to sleep at night or we go to bed at night, lying flat decreases peristalsis and decreases the benefits of gravity and exposes the esophagus to that acid. So there is a genetic risk, but there's not a single causative agent for GERD at all. So there's reflux esophagitis, and again, that's that lower esophageal sphincter. Eating large meals, certain foods, taking certain drugs, smoking, using alcohol, all influence the function of the lower esophageal sphincter. So again, look at table 49.1 and make sure that you know the contributors to decreasing lower esophageal sphincter pressure and putting the person at risk for GERD. So the reflux is generally sour or bitter tasting. Sometimes there's a reflex that people have that is salivary hypersecretion that occurs because of the reflux, and it's called water brash. So they get a lot of salivation due to that reflux. So when they get water brash, the patient reports a sensation of fluid in the throat, but there is no bitter taste or sour taste like there is in actual regurgitation from the stomach. Just remember that people who have NG tubes have a decreased esophageal sphincter function as well. The tube keeps the cardiac sphincter open and allows acidic contents from the stomach to enter the esophagus. So they've constantly got an opening there because the NG tube is going through there. If you look in the second column on page 1081, it says, during the process of healing, and they're talking about healing from GERD. I'm gonna go on here, and then I'll go through this piece in the book. So over time, the reflux material returns to stomach via saliva, peristalsis, and gravity. Inflamed esophagus cannot eliminate the reflux material. And then hyperemia or increased blood flow and erosion of the esophagus occur in response to the inflammation. So during the healing process, sometimes the body will substitute what's called Barrett's epithelium instead of a normal epithelium in the esophagus. So what we usually have as far as the epithelium that is lining our esophagus, it is squamous cell epithelium, which means it's a bunch of flat cells stacked on top of each other. Well, over time, the more esophageal reflux people have, the esophagus tries to protect itself. So it builds up this Barrett's epithelium, which instead of being squamous or flat cells, it builds up this columnar epithelium, which you think would be great. But the new tissue is columnar, so it's more resistant to the acid, and it supports that healing, but just so you know, it is pre-malignant, which means precancerous. So it's associated with an increased risk for cancers in those who have prolonged GERD. So we don't want people to have GERD for a long time because they could get esophageal cancer, especially if they find Barrett's esophagus. And how they find Barrett's esophagus is through the EGD, esophagogastroduodenoscopy. This Barrett's epithelium can also cause fibrosis and scarring with this healing process, and people can actually get strictures in their esophagus, allowing food not to go down. So that is also important to note. On page 1082, please note the key features of GERD. So here, difficulty swallowing due to stricture. So I just mentioned that. Asthma, laryngitis, dental decay, again, cavities from the acid going up possibly as far as the mouth, cardiac disease, aspiration, pneumonia, and hemorrhage. So those are all complications of GERD. So uncontrolled esophageal reflux increases the risks for these complications. And like I said a while ago, eating large meals, delayed gastric emptying, they can cause reflux as well. So small, frequent meals. Smoking and alcohol can influence the function of the lower esophageal sphincter. So can caffeine. Again, going to mention the NG tube can cause decreased lower esophageal sphincter function because there is a tube running through there and it keeps the lower esophageal sphincter open and it allows the contents to flow backwards into the esophagus. So signs and symptoms of GERD, these key features on 1082 in your book. Dyspepsia or indigestion, regurgitation, which may lead to aspiration, water brash, cavities, dysphagia, odynophagia, which is painful swallowing, pharyngitis, and coughing, hoarseness, or wheezing at night. So like people have asthma. Pyrosis or heartburn, chest pain, belching, nausea. So lots of signs and symptoms of GERD. Symptoms may worsen when the person bends over or if they strain, and if severe, pain may radiate to the neck, jaw, and back. And again, make sure you're looking at those key features. Atypical chest pain is thought to be caused by stimulation of pain receptors in the esophageal wall and by esophageal spasm. Should patients ignore this? What do you think? If they think they're having heartburn or indigestion, dyspepsia, are they going to ignore it? Just remember that that type of pain can mimic angina and can mimic heart pain. So if you run into somebody like this, make sure you're assessing it carefully, and they should not ignore it. So more signs and symptoms of GERD. So it says drinking fluids and taking antacids and sitting upright generally alleviates the signs and symptoms. So how do they diagnose GERD? Barium swallow study. A barium swallow is where they drink a solution and have x-rays taken. It can help show a hiatal hernia, which we'll talk about later, and it can also show strictures. An EGD, I showed you a picture of this in the assessment part, where they go down the throat for direct visualization. They can get biopsies while they do the endoscope. pH monitoring. They can actually take this through an NG if they want to, get some gastric samples or esophageal samples of fluid. So there are different ways to diagnose. There's lots of different things they can do to diagnose GERD. So I just wanted to show you, this is a swallow study, if you have not seen what that is. And this just shows they take different consistencies of fluid or food and have people chew and eat, and then they look at making sure that there's no residual left in that pharynx or at the epiglottis or in the where the cardiac sphincter might be. So they're watching how the musculature works. It's kind of cool. So for most patients, GERD can be controlled by nutrition therapy, lifestyle changes, and drug therapy. Nutrition therapy is used to relieve symptoms in patients with relatively mild GERD. So we limit or eliminate foods that decrease the lower esophageal sphincter pressure and irritate the inflamed tissue that causes heartburn. So if you look again at that, those foods that cause, or the substances, I should say, on page 1081 that contribute to LES pressure, like caffeinated beverages, coffee, tea, cola, chocolate, nitrates, citrus fruits, tomatoes, alcohol, there's that alcohol again, peppermint, smoking, use of tobacco. So NG tube placements is there too. Also high levels of estrogen and progesterone. So again, healthy eating habits, restricting spicy and acidic foods. Smoking and alcohol should be, cessation programs should be utilized. And then here are some other ways to manage. Sit upright for an hour after meals. That's a good one. Some people go so far as to sit up in a recliner and sleep in a recliner at night. or put the head of their bed at home up on blocks so that their head is constantly higher than their feet or their stomach. Lifestyle changes. So here we go. Elevate the head of the bed 6 to 12 inches for sleep on blocks or use a large wedge pillow. Right side lying position to promote gas exchange. Swallow frequently to clear the esophagus. Weight reduction options. Avoid restrictive clothing and bending or lifting heavy objects. And if the person has obstructive sleep apnea, they need to possibly use a CPAP. So drug therapy for GERD. Let's see who that is in my book. I think that might be in the next chapter, actually. So the main categories are antacids, histamine blockers, and proton pump inhibitors. And I'm sure that you have heard of all of those in pharmacology. But those are in the next chapter, I believe. Let me make sure. If they're not, I will come back and do them, but I think they are. So anyway, you've heard of all of these. Antacids are effective for an occasional episode of heartburn. They raise the pH to a more basic level than an acidic level, and they deactivate pepsin. Their length of action is very short. Antacids increase the lower esophageal sphincter pressure and therefore are not given for long-term use. Some antacids contain aluminum, others contain magnesium. Some people don't like to take aluminum, but then the magnesium, people can overdose on that. And they can also get diarrhea in higher doses of magnesium. Liquid forms of those are preferred to coat the esophagus to provide better pain relief. Histamine blockers like Pepcid. Pepcid is one that you should give patients at bedtime because it decreases the amount of acid production during the night. So that is always a good thing, especially if they are in a recumbent or lying down position. So Pepcid, Tagamet, Zantac, those are just examples that decrease acid secretion and promote healing of the inflamed esophageal tissue. Then you've probably heard of proton pump inhibitors such as Prilosec and Protonix and Nexium and Prevacid. They're the main treatment for severe GERD, and they are long-acting, and they inhibit gastric acid secretion by affecting the proton pump of the gastric parietal cells that give us hydrochloric acid. So just FYI, I'm sure we'll be going over those in the next chapter. So surgical management for GERD. The ones I want you to know are, so basically a very small percentage of patients with GERD require anti-reflux surgery. Sometimes people get this surgery because they also have a hiatal hernia, which we'll talk about just in a little bit. But Nissen fundoplication, Nissen, N-I-S-S-E-N, not a Nissan car, but a Nissen fundoplication is a minimally invasive surgery and is a standard surgical approach for treatment of severe GERD. So people usually have that because they have a hiatal hernia that's pushing up through pushing their stomach into their thoracic cavity. So here's a Nissen, and basically what they do is they take the fundus, and this is why they call it a fundoplication, is because they take the fundus of the stomach and wrap it around the esophagus and tie it to each other. They sew it together so you can see, as the picture shows, exactly what it looks like after surgery. So basically they are improving the pressure in the lower esophageal sphincter by doing this surgery. That brings us to hiatal hernias, also called diaphragmatic hernias. Occurs when there's a protrusion of the stomach through the esophageal hiatus of the diaphragm, or the hole in the diaphragm that the esophagus goes through, so that the stomach pushes into the chest because of the weakening of that diaphragm. So there's two main types. There's sliding hernias, which are the most common, and periesophageal or rolling hernias. Hernias generally move freely and they slide into and out of the chest during changes in position or intra-abdominal pressure. So the big problem here is that there's esophageal reflux and those associated complications. These can become twisted, called a volvulus, and they can make an obstruction in the GI tract, so no food can propel forward. Rolling hernias or periesophageal hernias, same thing. The gastroesophageal junction remains in its normal position, but the fundus rolls through the hiatus. Here, let's look at that. There's a picture. There is a picture on page 1086 of the different types. So there's the normal stomach, and you can see the diaphragm. You can see where the stomach sits below the diaphragm and how the esophagus goes through the hiatus of the diaphragm. So in a sliding hiatal hernia, the stomach is constantly pushed up in to the thoracic cavity. So the lower esophageal sphincter it's kind of almost open, so it slides up and down. So that person with a sliding hiatal hernia is going to have heartburn that just will not go away. On page 1086, they have key features of hiatal hernia. So sliding hiatal hernia, it says heartburn. So like I just said, they have constant, almost like heartburn, regurgitation, chest pain, dysphagia, and belching. And with a periesophageal or rolling hernia, part of that fundus goes up through the hiatus, and they feel full because basically their stomach is smaller because the big part of their stomach is in their thoracic cavity. So they feel full since it's almost like their stomach is smaller. Breathlessness after eating, because again, there's that big piece up in their thoracic cavity, making them unable to breathe as well. A feeling of suffocation after eating. Chest pain that mimics angina, and again, they should not ignore this. They need to go to the emergency room and see what that's all about if they have chest pain. And worsening of symptoms in a lying down position. So make sure you know those key features. So surgery may be required when the risk for complications is high or when damage from chronic reflux becomes severe. So again, that's a Nissen fundoplication is the most common surgery that they do. Make sure you know the difference between the two types of hernias, the rolling and the sliding. So this is what you want. The stomach perfectly under the diaphragm. Therefore, people will not have GERD. And this is the same picture that's in your book, just showing you a normal, where the stomach should normally be, a sliding hiatal hernia and a rolling hiatal hernia. And here again are the key features of hiatal hernia, and that is on page 1086. So when you're taking care of somebody with a hiatal hernia, education is one of the most important parts of nursing care. So we need to teach people the same thing we teach them if they have GERD. So they need to for one thing, sit up after they eat. And they can also, raise the head of their bed, or they can sit in a recliner, whatever they need to do. So again, they can diagnose they can diagnose hiatal hernias with a barium swallow study with fluoroscopy, or they can also see that on an EGD. So non-surgical management, again, is going to be drug therapy, nutrition, and lifestyle changes. So sliding hiatal hernias are most likely treated medically. Large rolling hernias can become obstructed and strangulated, so surgical procedure may be necessary. I already mentioned drug therapy of antacids and proton pump inhibitors, just like with for GERD, same thing, same type of thing we treat with. And nutrition, again, follow the same guidelines as for GERD. Surgical management are for those people who are at high risk when there's damage from chronic reflux is severe. So pre-op care, if the surgery is not urgent, the surgeon may instruct a patient who is overweight to lose weight before surgery. Any patient who is to undergo surgery for hiatal hernia is advised to quit smoking. Important. Basically, any surgeon who is going to do a surgery is going to tell a patient who smokes to stop smoking, because smoking constricts blood vessels and robs the tissues of good oxygenated blood, so they don't heal as well. So there is no surgeon that I would imagine is alive that would not tell the patient, to stop smoking before they had surgery. So again, laparoscopic Nissen fundoplication is a minimally invasive surgical procedure commonly used for hiatal hernia repair. There's also a transthoracic approach where they actually go in through the chest. And again, there's a paraesophageal approach as well. So post-op, the nursing care priority is to observe for complications and provide health teaching. Post-op complications, dysphagia, gas bloat syndrome, and aerophagia. So make sure that you are watching your patient when they take their first oral feeding, because temporarily they could have trouble swallowing. And again, you have to consider that airway. They may have to have dilation of a fundoplication if it's too tight. So you always want to make sure you're watching them when they eat the first time. Gas bloat syndrome is when patients are unable to voluntarily belch. Well, I can't even do that. But avoid carbonated beverages and eating gas-producing foods like high-fat foods. They shouldn't be drinking through a straw or chewing gum postoperatively. And then aerophagia means they're swallowing air. So they need to relax after they eat so that they're not swallowing air. Eat and drink slowly, chew their food thoroughly, so again, they're not swallowing air. Interventions post-op is that they need to frequently change their position, and they need to ambulate also very frequently. Before we go on to esophageal tumors, I want to go back to, because I think I know I have a picture of it in a magazine that I have, that I was going to bring. But when they're talking about GERD and that lower esophageal sphincter, there's another procedure called the, I believe it's LINX, LILNX or something. But anyway, that is magnets that are, it's a device that is a ring that are magnets that go around the lower esophageal sphincter and help, like they attract each other, so they help the lower esophageal sphincter to stay closed. So I wanted to mention that before we go on to esophageal tumors. Another thing to say before we go on is on page 1087. This is just a nursing safety priority action alert. It says the primary focus of care after conventional surgery for a hiatal hernia repair is the prevention of respiratory complications. I don't know how many times I can say this, but airway, airway, airway. Elevate the head of the patient's bed at least 30 degrees to lower the diaphragm and promote lung expansion. Another thing, if you look on the right side, or in the second column there, assessment of post-op complications related to fundoplication, it lists as a complication atelectasis and pneumonia. So the assessment and findings are dyspnea, chest pain, or fever. But all I can tell you is anytime anybody has surgery, you've probably learned in fundamentals already to encourage the person to do incentive spirometry and some deep breathing exercises to help them prevent those complications from happening. So that's all I wanted to say about that. So esophageal tumors can be either benign or malignant. And this starts on page 1088. Esophageal sphincters can be benign. Most are malignant, and the majority develop from the epithelial tissue, like squamous cell carcinoma, like you saw on that person's tongue. Adenocarcinomas are more commonly found in the distal third and at the gastroesophageal junction, and are now the most common type of esophageal cancer. The deal about esophageal tumors is that they grow really fast. And they can protrude into the esophagus, and they can invade the surrounding tissue. It makes people not be able to swallow. So risk factors are, again, alcohol intake, people who don't eat fresh fruits and vegetables, diets high in nitrates, like people who really liked a lot of smoked meats and things like that. Those have lots of nitrates in them. Malnutrition, obesity, smoking, and untreated GERD all contribute to esophageal tumors. Signs and symptoms. Esophageal tumors can be silent, meaning they don't have any signs and symptoms. So in the early stages, it is a silent tumor. By the time the tumor causes symptoms, it usually has spread extensively. And of course, one of the most common symptoms of esophageal cancer is dysphagia, difficulty swallowing. I mean, food does not push through there because there's a big tumor there. So that kind of stands to reason. Diagnosis of esophageal cancer, again, they're going to do a barium swallow because they could see the margins of the tumor with a barium swallow. Esophageal ultrasound, they have a definitive diagnosis. They could do a biopsy or an aspiration to look at the tissue of the tumor. They can do an EGD, but Sometimes if they see a tumor when they're starting to do an EGD, the GI specialist will not like try to push that scope across the tumor because they could harm it. I don't know how else to say it, but they don't want to cause like a bleeding or a hole there. So they might take a biopsy or something of it, but may not push through the cancer, the tumor. A PET scan identifies metastatic disease and helps evaluate a person's cancer treatment. It stands for positron emission tomography, and it's a imaging technique that uses radioactive substances that are called radiotracers to visualize and measure changes in metabolic processes. So like blood flow and chemical composition and absorption. That's how they use the PET scan. So there's high anxiety with the diagnosis of esophageal cancer. Distressing symptoms. It's a terminal illness, obviously, and of course the people have a fear of choking because there's this big tumor. So ask the patient about how they cope and any resources, and you can also, help them get counseling if they need it. So with esophageal cancer, there's always a potential for compromised nutrition because of impaired swallowing and possible like metastatic disease. So nutrition and swallowing therapy may be in order, like a speech therapist may have to help with some swallowing exercises and that type of thing, as far as non-surgical management. Now, if somebody comes in and has like signs and symptoms of poor nutrition, some people come in and they have a big swollen red beefy tongue, and so that usually is a symptom of poor nutrition. And so a cancerous tumor that's gone on for a long time and robbed a person of their nutrition, somebody can come in like that. They may, and maybe they're having trouble swallowing. Well, if that person is debilitated and they're having trouble swallowing, you don't want to necessarily feed them and give them stuff to drink unless you know that they can swallow. So they need to have a swallow study before you start doing any of that. So on page 1090 or 89, it says, first of all, collaborate with a speech language pathologist to help the patient with oral exercises to improve swallowing, and with the occupational therapist for feeding techniques. But under that nursing safety priority under critical rescue, when the patient with an esophageal tumor is eating or drinking, recognize that you must monitor for signs and symptoms of aspiration, which can cause airway obstruction, pneumonia, or both, especially in older adults. So you want to make sure that these people have a swallow study before you start feeding them. So on this slide, it says, of course, the treatment for esophageal cancer, if somebody's got a big tumor, surgery is the most definitive intervention that they can have to take. So they may have an esophagectomy. So esophagectomy, esophagogastrostomy, pyloromyotomy, we're not going to go through all those, but I am going to tell you again to keep the patient in a semi-Fowler or high Fowler position to support ventilation and prevent reflux. Also, page 1090, and the action alert, respiratory care is the highest post-op priority for patients having an esophagectomy. These people are going to come back from surgery with an NG tube. Now think about that. They have a nasogastric tube. They had work done on their esophagus. An NG tube goes through the nose, through the esophagus, into the stomach. So if they've had something done to their esophagus, what are you going to want to do with that NG tube? What if it's not patent? What if it's not patent and somebody starts complaining, oh, my stomach really hurts and their abdomen's getting distended? Are you going to irrigate that? Do not irrigate or reposition the NG tube in patients who have undergone esophageal surgery unless prescribed by the surgeon. So if you get some kind of blockage in that thing, if they're suctioning out, whatever stomach contents, if it gets blocked, don't do anything to it unless you contact that surgeon first. I just want to put this picture up here. This is esophageal diverticula. So we'll talk about diverticulosis and diverticulitis in lower GI, but I wanted to kind of show you a picture of diverticula, or just sacs, or outpouchings of the tissue. And as you can see, things can get caught in there. So this is esophageal diverticula. And again, they will see these on an EGD. But again, if somebody had these, they would just remove them surgically, or they could control the symptoms using nutrition therapy. But this isn't mentioned at all in your book, so you don't have to worry about this. But I just wanted to make sure you knew what diverticula were, and that they do occur in the esophagus. Esophageal trauma is mentioned in your book on page 1092. And just you need to know maybe what some common causes are, and you may have talked about this somewhat in pediatrics. But trauma to the esophagus can be any blunt injury or chemical burn, surgical, endoscopy, like running an endoscope through there. They can always perforate it. Unfortunately, that could be a thing. Patients with esophageal trauma are evaluated and treated in the emergency department. But make sure, again, we look for airway patency, breathing, chest pain, trouble swallowing, vomiting, bleeding are all priorities for patient care. The patient needs to be kept NPO to prevent any further leakage of esophageal secretions, and prevent sepsis in these patients. So yeah, that took longer than I expected. But anyway, that is installment for the oral cavity and esophageal problems. So thank you very much.